Welcome, everyone. We'll get started here in just about 1 minute, but appreciate you being here today at our second workshop on innovations in hypertension control. So we'll get started here in just a moment. All right, welcome everyone. It's right at the top of the hour. Thank you for joining us in our second workshop on innovations in hypertension control. We're going to have a panel discussion today on COVID-19 and hypertension. My name is Rochelle Bartnick. I'm the Senior Community Impact Director with the American Heart Association based in St. Louis. I cover the metro region of St. Louis as well as outstate Missouri. And as most people know, the American Heart Association has made it a priority to address hypertension and help organizations, individuals in our community control hypertension going forward for longer, healthier lives. So I'm excited for this discussion today, and I'm excited for all the experts that we were able to bring around the table. This series is done in collaboration or in partnership with my friends across the state. Again, I'm Rochelle Bartnick with the American Heart Association. Another collaborative partner is Chris Comerfield with the Missouri Department of Health and Senior Services, and Marianne Kimball with the Health Quality Innovation Network. This is the second year we've put on a series like this, and they are certainly outstanding partners, so I thank them. Real quick, I just wanted to highlight how you can control your view. You know, you have control over that. Many of us have been using Zoom for the last few years. But there are some tips on your screen for you to be able to adjust the way that you see things, scroll from back and forth to be able to see the speaker view and the slides being shared. And I know this is a common question that we get in our chat. We will share the video, the recording, as well as the slides and any resources that we mentioned today after the webinar ends. We do want you to engage with us throughout this hour, so please do use the comment box. Be sure to change the to section to all panelists and attendees if you'd like everyone to see your comments. And then at the end, we have saved time for audience questions. We ask you to use the Q&A feature in the webinar to be able to answer or to ask those questions. If we can answer them live, we certainly will, but we can also type in our answers. So the Q&A section is a perfect spot for that. All right. Well, with that, I'd like to turn the microphone over to Mr. Chris Comerfield, and he's going to introduce our topic and our moderator today.
Thank you very much, Rochelle. It is very important to highlight hypertension education in Missouri, since 9.7% of all deaths in 2020 had high blood pressure listed as either a primary or a contributing cause of death. Worldwide, high blood pressure accounts for 12.8% of all deaths. This was just 1 year, but Missouri resident hypertension and heart disease deaths have statistically significantly increased in 2020 compared to 2019. One of the topics that has generated considerable discussion during the last few years is COVID-19 and hypertension. COVID-19 infection can have symptoms that last long after the initial infection. Experts in the field will discuss emerging information on hypertension management in patients with long-haul COVID. And now it is my privilege to introduce the moderator for today's session, Dr. Stephanie Hawkins. And let me tell you a little bit about Dr. Stephanie Hawkins. Dr. Hawkins has been an ambulatory care pharmacist in geriatric primary care at Cox Health Senior Health Center for 7 years. In this role, she focuses on improvement on population health outcomes, including diabetes, hypertension, and hyperlipidemia management. She also serves as postgraduate year 2 ambulatory care pharmacist preceptor for research in primary care. Currently, she is working on research focused on improving access to continuous glucose monitoring in geriatric populations and serves as a member of the Professional Affairs Committee for the Missouri Pharmacy Association. So, Dr. Stephanie Hawkins, take it from here. Thank you.
Well, thank you very much, Chris. I very much appreciate that introduction. And welcome, everyone. We're so glad that you chose to spend some time discussing this important topic with us. I looked up on the CDC website that from January 2020 to May 22nd, there's been over 83 million Americans affected by COVID. So this is a growing importance to look at chronic disease state management, particularly because so many people have the potential to be affected by long-haul COVID symptoms. And so I have the honor today of being able to introduce you to our panel of experts. So I will do that. And then Dr. Chelsea Hawley will introduce us to a little more to the background and literature that's known in this topic area. And then after that, we'll open it up to some questions for our experts, and then further open it up to audience questions. So please do, as you hear things and it sparks interest, please post those questions to the Q&A and we'll get to as many as we can. So thank you very much for that. So first I'll introduce you to Dr. Chelsea Hawley. She is a practicing ambulatory care pharmacist in primary care at North Kansas City Hospital. Her current role involves improving population health outcomes with a focus on diabetes management. She is currently working on projects for her medication therapy services, diabetes management protocol, and teaching living with diabetes classes to newly diagnosed patients. We also have with us today a board certified nurse practitioner, Ibrahim Alamad. And he is a practicing family nurse practitioner at Cox Health at the East Battlefield Clinic in Springfield, Missouri. He is a former board member of the Advanced Practice Nurses of the Ozarks and a member of several advanced practice nurse practitioner groups. His current role includes primary care, acute care, and telehealth. During the COVID-19 pandemic, he has treated patients both in clinic and remotely and sits as a consultant for optimizing virtual visits for the system. He is currently working on a joint pilot project involving enhancing physician advanced practice practitioners relations and reducing provider burnout throughout the system. Part of this project involves utilizing system resources to enhance patient care and limit redundant processes. Kendall Stevens is a respiratory therapist at Cox Health since 2007. And after 9 years in the hospital, she transitioned to the cardiopulmonary rehabilitation clinic in 2016. Most recently, she developed a multidisciplinary plan for long-haul post-COVID patients. She enjoys the outpatient pulmonary therapy teaching aspect of her current position and seeing the positive outcomes after patients complete the program. Now she has been engaged in something at the last minute today. And so she may have to log in later or may not be able to make it today, but we will try to incorporate her as she has time to join us today. But with that, I would like to transition to Dr. Chelsea Hawley to tell us a little bit more about long-haul COVID and hypertension management.
Thank you very much for that introduction, and also thank you for the panelists who've also joined today, and for everyone involved for allowing me to be here and speak. So like she said, today we will go over COVID-19 and hypertension, what that looks like, and hopefully this slide deck provides a little bit of value and pretext to the discussion that we'll have in the Q&A after. So next slide, please. So first, I want to talk a little bit about timing. There are quite a few different terms that are thrown around dealing with long COVID. Now, both post-acute COVID and this chronic COVID do offer umbrella terms that really refer to all COVID-19 symptoms beyond that initial phase of COVID infection. For post-acute COVID, that refers to persistent symptoms at least 3 weeks after the initial COVID infection, whereas chronic COVID, and most often referred to as long COVID here, refers to symptoms lasting more than 12 weeks. And that is analogous to the World Health Organization and what their definition for long COVID also is. Next slide, please. So with COVID long haulers, oftentimes they often have symptoms that last for quite a while after that initial infection. They can be a myriad of symptoms. There was a single center study in Italy that found patients who had recovered from COVID-19, even up to 87.4% reported persistence of at least one symptom. That could be anywhere from chronic fatigue, which is a really common one, as well as brain fog, arrhythmias, shortness of air, achy joints, loss of smell or taste, as well as hypertension. Next slide, please. So now that we've kind of got an idea of what the definitions are, as well as what the symptoms can be, I want to specifically look at the pathophysiology of what COVID-19 and new onset hypertension looks like. Next slide. So the proposed mechanism, there are many proposed mechanisms, but this is largely one that predominates. COVID-19 comes in into host cells via ACE2, which is angiotensin converting enzyme 2, and that downregulates and decreases that H2, ACE2, which causes subsequent increase in angiotensin 2 levels, and then that may lead to an increase in blood pressure. Also, that angiotensin 2 has pro-oxidative as well as pro-inflammatory actions, which also promote excessive endothelial dysfunction due to that elevated amount. So it's really a dual mechanism of that dysregulation of that renin-angiotensin system, as well as the endothelial dysfunction that promote those hypertensive symptoms. Next slide, please. So now we'll go ahead and take a look at some current literature that I've reviewed that really shows and sheds some light on this topic. Next slide. The first study that I want to look at is, does COVID-19 cause hypertension? This was a single center retrospective cohort study that had 211 patients admitted to the hospital for severe COVID-19. Now, they found that new onset hypertension was observed in about 18% of patients, or 18 patients or 12% during that post-COVID-19 follow-up period, which was around 31.6 days on average, and that was statistically significant. Now, both the systolic and diastolic blood pressure were significantly higher in the post-COVID-19 period compared with on admission. And then just to orient you a little bit to the graph on the right, the systolic and diastolic is on admission, and as well as that post-COVID-19 follow-up period. For systolic, what those exact numbers are, but on admission, that was 120.9 millimeters of mercury, compared with on the follow-up period was 126.5, as well as with the diastolic, it was 78.5, compared with 81.8 on the post-COVID-19 follow-up period. Next slide, please. The second study I'll take a look at is hypertension as a sequelae in patients of SARS-CoV-2 infection. Now, this was a single center retrospective study in Wuhan, China, that looked at 366 hospitalized patients. 16 patients, or 8.42%, without prior hypertension had a rise in blood pressure during this hospitalization. And this study actually concluded that hypertension may occur in these COVID-19 patients and even can become chronic disease. And with the graph to the right, you can see that the systolic blood pressure was elevated throughout admission and for the most part declined on the late follow-up period, but not for all patients. Next slide, please. And the last study I want to look at is called Lochinvar. This is actually an ongoing study that is looking at longer-term effects of COVID-19 infection on blood vessels and blood pressure. It is still in the recruitment status. It is estimated to complete here in about 2 years. It's observational prospective case control study with around 150 patients. And this is a really exciting study because they actually already have preliminary results that show participants with this previous COVID-19 infection had an 8.6 millimeters of mercury increase in their average 24-hour systolic blood pressure. So I found that to be really interesting and at least a highlight of kind of what we're seeing for patients in this post-COVID-19 follow-up period. Next slide. So now we'll talk a little bit about management, especially for new onset hypertension in the post-COVID-19 follow-up period for long COVID. Take a look at how we treat and manage these patients. Next slide. So we always want to continue to recommend non-pharmacologic therapy, such as following a healthy diet, such as the DASH diet, getting high quality sleep. There have been studies that have shown that if you get less than 7 hours of sleep, 6 or less, that may lead to increases in blood pressure. So we recommend at least 7 hours of sleep for most people. Also limiting alcohol intake. So that's going to be 1 drink per day for women or 2 drinks per day for men. Limiting caffeine intake, which will be less than 200 milligrams of caffeine per day, which is the equivalent to about 2 cups of black coffee per day. And then as practitioners, we always want to recommend smoking cessation or not smoking for our patients. And then speaking with your doctor about your blood pressure medications. There is always the recommendation to continue guideline-directed therapy and then with medications to tailor those specifically to the patient, their needs, their labs. And then I do want to make a point to mention at the beginning of the COVID pandemic, there was a lot of controversy regarding ACE and ARB inhibitors as those related to the COVID-19 entry mechanism. So a couple of different organizations, the Heart Failure Society of America, American College of Cardiology, and American Heart Association issued a statement recommending continuation of these RAS antagonists for hypertension according to current guidelines, regardless of COVID-19, because we do want to continue to treat that patient's hypertension. And there have been multiple studies that show no evidence of that ACE or ARBs really affect or risk of COVID-19. So I do recommend continuation of those if patients were on those previously. Next slide, please. So hopefully that gave us a little bit of a perspective going into the discussion about hypertension and long COVID. If you guys have any questions that we don't get to in the Q&A here today, feel free to reach out via email. I'd be happy to help answer those.
Thank you very much, Dr. Holly. I have a few questions and then we'll ask Abe to come on camera to kind of start our discussion. Hello. And so one of the things we want to know from clinical practice, where you're seeing patients, both virtually and in person after their initial infections are over, are what implications for hypertension management and cardiovascular care have you seen in clinic for these patients that have recovered from their initial infection but may have lingering symptoms?
So seen exacerbation in hypertension and other cardiovascular diseases to those patients who had previously had them or had extended, post-COVID symptoms. And generally, this is likely from the cardiac demands from the disease, hypoxia, stress cardiomyopathy, those acute pneumonia symptoms, pulmonary embolism, myocarditis, all been associated with exacerbation of disease and increased workload of the heart. apart. So it seems to be the main factor that's causing this extended, these extended COVID symptoms in my experience.
Excellent. Thank you for that insight. And then also, we see a variety of different patient care groups, right, in clinic. And some of these patients maybe have less reserve function. So I know I work with a geriatric population predominantly. And so just in clinical practice, but then also in the literature, it's starting to indicate that maybe there are some groups of people that are more affected by long haul COVID symptoms, and particularly disease state management for those patients. And so that's one of my questions also is, are there population groups that are more adversely affected by hypertension due to long haul COVID symptoms? And then how can the needs of those groups be best addressed?
Stephanie, in my experience, it seems like more vulnerable populations with limited access to treatment due to either socioeconomic determinants or those in unvaccinated, or like you mentioned, people with multiple comorbidities or advanced disease processes such as COPD, kidney disease, coronary artery disease, heart failure. Those seem to be more affected by, post-COVID or long haul COVID symptoms. And, as far as addressing those needs, it's always been frequent evaluation and early treatment, offering telemedicine appointments at reduced cost or no cost to the patient, or frequent follow-ups and treating those underlying comorbidities to help reduce those poor outcomes.
Excellent. Yes, you're always having ongoing discussions and communication with those patients and trying to find ways to get them re-engaged, right? And so that's another question is, are there patient engagement strategies that you've found that have been more successful to improve hypertension management in this particular patient population group?
So yeah, as I just mentioned, having that patient contact, either virtual or in person, is really vital. Kind of assessing the patient knowledge about their disease process and ensuring that they're compliant with their designated treatment, be it medication or physical therapy, or just developing those knowledge bases, and then utilizing other members of the healthcare team, be it therapists, pharmacists, clinical staff, contacting them either in person or by phone has really been helpful. And then big thing is, following up in a timely manner to find out those barriers to care, whether it is, cost or coverage concerns regarding medication compliance or lack of tolerance to medications, or even just assessing the patient's understanding of how and when to take their medications, because that can make a big difference.
I would imagine too that some of the secondary causes of hypertension come more into play as well as we assess these patients, since a lot of them require O2 supplementation or CPAP at night where they didn't require it before. And so now we have some additional secondary causes for uncontrolled hypertension also. And so kind of along the lines of re-engaging people and reasons that people have not been able to continue care throughout this pandemic. Chris mentioned earlier that from 2019 to 2020, Missouri saw a 22% decrease in emergency room visits for essential hypertension. And it also led to an increase of 109 additional deaths over the year, marked by hypertension. And so my question for you is, what role do you think COVID played in this situation, in these statistics? And are there strategies for ensuring that patients are able to re-engage? How can we reach them and help them with maybe their fears of being seen or being exposed to COVID? Are there remote monitoring opportunities or something along that line?
Yeah, so, in 2021, especially with the Delta variant spike and then subsequent Omicron surge, ER wait times ballooned, with, many patients going in to be treated or being tested for COVID. And I feel that has been a detriment for a lot of patients with hypertension or those comorbidities, fearing to catch the disease going into the ER, and so thus delaying care and delaying treatment. And that was kind of one of the big complaints from one of my patients, is that they didn't want to go to the ER if they had to wait 12, 14 whole day just to be seen. And so it just increased their risks, and we tried to mitigate it. But honestly, some strategies that we've tried to encourage, at least in my clinic, is making those touch points via telemedicine, or trying to see them in clinic, and try to mitigate as much as we can, keeping them away from urgent cares or crowded centers where they could be exposed, or suffer lack of treatment or improper treatment. So it's staying on top of things, and providing that reassurance, and that they're going to be seen one way or the other.
That's excellent. Yes, in clinic, I've also had that situation where you're trying to make sure that your patients that have limited exposure, but at the same time take care of them. And sometimes you need a few extra touch points built in there too, to help get kind of through that period of time. That's excellent information. And I'll highlight too from the last session that Dr. Annie Eisenbeis mentioned, the use of blood pressure cuffs that have a remote monitoring link. And I could see that being incredibly helpful for helping to continue to engage with patients in monitoring, whether it's because of a COVID pandemic or otherwise, because transportation can always be an issue or a limitation in clinical care. So I could see that as well. I really appreciate your discussion and talking with me about some of the issues related to this situation. I think at this point we can open it up to our audience questions.
Wonderful. Thank you so much. So to everyone, we can use the chat feature to ask our panelists questions, or we can use our Q&A section to ask our panelists questions. We did have one come in while you were engaging with the panelists. And it is, does COVID-19 increase the risk of acute ischemic stroke?
I would say yes, just because of the processes involved. I mean, I don't know how specific you want me to answer that question, but I would say as a general principle, yes.
I would agree. I don't know if there's data to support that it for sure does, but theoretically, if it increases your risk for hypertension, increases inflammation, pro-oxidative effects, stress effects, just having hypertension alone is a risk factor. So I think that would inherently increase the risk for stroke as well. And then a lot of the studies, I don't know if I mentioned, mostly were done in more severe COVID. So I think that's also another consideration. If it's less severe or more severe COVID, how much inflammation is there present for those patients? And that probably also is a factor.
I'll also mention additionally, on top of what's already been said, we think about, maybe beyond the hypertension management focus is the kind of the fatigue that can occur, and it can be really severe in long haul COVID to the point that it limits people's activity and their exercise and some of those other lifestyle pieces that we know are really important for reducing hypertension risk and therefore important for reducing stroke risk as well. And we have seen some data about an increased coagulation or coagulopathies in this patient population, at least in the acute infection situation. So overall, I would think that would increase your risk in the long-term picture as well.
Great. Yeah, thank you. And so just a reminder again to our audience, you can type your questions in the chat box and then press enter, make sure it's set to all panelists and all attendees. And so we did have a question come in through the Q&A box, and it It is as follows. Is the treatment different for hypertension with long haul COVID, or is it similar to hypertension treatment without a COVID history?
I can speak for my portion of that. From what I've found, it is very similar. You just have to take in the patient-specific characterizations, like if they want to take medications once a day versus twice a day, as well as cost and those barriers, in addition to labs, and is more just guideline-directed therapy as far as I'm concerned, what I have seen. Abe, feel free to speak differently if you feel otherwise.
No, I would agree. I would agree. And, usually it develops with whatever comorbidities the long haul COVID is, be it like heart failure or, just hypertension from increased, stress from, the long disease. So just depending on the type and specific, issues the patient is having, you would treat them the same.
All right. We don't currently have any questions and additional questions in the Q&A. And just invite the audience, if you have any burning questions out there, please do drop it in the chat or the Q&A box. I can bring Chris Kummerfeld back on. Is there anything, Chris, that you would like to ask our panel?
What
On
about
the spot there?
yeah, I was just unmuting myself and putting it. Is there any special considerations with diabetes and long haul COVID and hypertension?
For me, not necessarily to my knowledge. Obviously, those patients who have comorbid conditions are going to require a close follow-up, as we've previously stated, but I don't think that their care is going to differ in any way just because that they also have hypertension and then subsequently got diagnosed with COVID. Still, those same barriers that we had previously would need to be addressed in a more close follow-up, definitely.
Yeah, and I would agree. Managing those underlying diseases is going to be really important. And so as long as you are, following up on a regular basis and ensuring that those things are taken care of, I think it's essentially the same.
I would agree with that too, following guidelines and guideline directed therapy and making it very patient specific. But also one thing that I have seen occur is in the initial infection, we rely on steroids quite a lot. And so kind of keeping that to the forefront of your mind that your patient probably was exposed to some type of steroid or other therapies that could also play a factor in both their diabetes, management and control, and also their hypertension management and control, because we know those are agents that can cause our blood pressures and our blood sugars to be higher.
Yes.
So I would just keep that in mind as well as you're kind of looking over their clinical picture and kind of looking back to what maybe agents they were utilizing and what their picture looked like before, kind of during the infection and then afterward. And then also flavors have been an issue for my patients. Their taste receptors are very different after COVID infection, which is something I never thought I would be thinking about as a clinician, like having to think about, what things taste like to people, but it can be a very metallic taste for some foods. And so then they switch their diet somewhat because of those different palates at that point in time. And that can help some depending on what they switch to. And that can also make it more difficult. And then of course, we've talked about social determinants of health in the past. And, during the COVID pandemic, the easiest kind of safest way to get food without exposure was through delivery or fast food. And those are typically very high salt salt diets and very high fat diets and very high carbohydrate diets. And so that certainly is a factor in chronic disease state management and what your patient can, one, what they want to eat, and then what they can afford to eat and how can they get it safely. That can very much change that lifestyle management, and then also their disease state picture, and you helping them as a clinician find a way to manage that.
Stephanie, I wanted to ask, were the metallic tasting foods typically the ones that were good for you and healthy, or were they typically the ones like ice cream or something bad for you?
Strangely, it was proteins like meat, but in diabetes care, of course, we want to rely somewhat on proteins to help stabilize glucoses. So in that particular case, they really leaned more on fruit. That's what they could actually taste and wanted to eat. Well, of course, that is difficult to maintain a good control on blood glucoses if you're going to eat majority of your diet is going to be fruit throughout the day. So we've worked on that. It has improved over several months, but you lose a little control in those situations. And of course, when you're talking about patients that have a small amount of reserve function, but they have multiple comorbidities and multiple medications that affect all of those things, it gets a little more complicated in that situation. So then you do have, that affecting hypertension management as well.
Thank you.
Great
I was just
question.
curious.
Yeah, and to kind of pair alongside with that, I mean, diabetes management, the fatigue is one big thing I've seen a lot with my patients. And like you said, when they're fatigued, they're not going to want to exercise or maintain those, that cardiovascular health. And so, they do see their, some weight gain, and their A1C slowly sliding up. And so, it can be a struggle, but thank you for sharing that. That's a good insight. So appreciate it.
Yeah, and again, a reminder to the audience, if you have a question, or if you would prefer to ask the question live, we certainly can. You can raise your hand and we can unmute you. We did have a question come in. Thank you for that. Has there been an increase now on self-measurement of blood pressure programs to accommodate for this long-haul symptoms of hypertension due to COVID?
Well, it wasn't. We've had some new programs. They are not directly attributable to long haul COVID and hypertension, but we have new SMBP programs called Accelerating SMBP across Missouri, and we have Healthy Heart Ambassador programs that are being launched in Missouri, but they're not as a direct result of long haul COVID and hypertension per se.
And I will say, I'll jump in too. The American Heart Association nationally has partnered with HRSA and the Office of Minority Health to launch the National Hypertension Control Initiative. And so, that is the SMBP, self-measurement of blood pressure, is a critical component of that. And I think, again, not directly attributed to the patient that is dealing or has dealt with COVID and hypertension, but more at a reason that because of the COVID pandemic, so many things have changed within patient care and within our communities, that we just want to be able to kind of elevate of that and support communities in supporting patients with self-measured blood pressure. So yes, I think because of the pandemic, many things have been created, and hopefully we'll be able to hear some of those successes and some of that more about the National Hypertension Control Initiative at our next session on June 1st. Any other questions, comments?
So I'll comment. I know in our clinic, we do use the SMBP program through the DHSS provided program. And so we have really emphasized that a lot more over the last 2 years, partially because we couldn't bring our patients into the clinic, and we needed a really good standardized way to make sure that they were all being educated on how to take appropriate blood pressures at home, making sure they had access to devices that were going to be validated and appropriate and give us the most accurate blood pressures possible. The other thing is we see quality measures, particularly under Medicare and from CMS, weighing in on making sure that your patients are meeting their hypertension goals throughout the year and that they're appropriate for that patient and you're monitoring well. So that kind of, Chelsea and I both work on population health goals, but I would say that actually anybody in healthcare at this point is going to have to work on population health goals, and because of some of those pushes. And that's great. That gets more of our patients healthier. But because those are big aims and big goals, then we have really strategized around that and trying to push for better self-monitoring and better patient empowerment and engagement in our clinics. And then the other thing is that the pandemic actually opened up some payment options for remote monitoring of your patients, which is great because we're spending a lot of time doing that now. And so it's good to have an option for being reimbursed for some of that time that you're engaging with the patient on doing self-monitoring and reviewing their measurements and doing that education with them to help them reach their healthcare goals. Is that something that you're seeing much, Abe or Chelsea, in your clinics?
We are. Yeah, it's generally one of those things that is managed by population health. And we do have, our clinical pharmacist that actually kind of jumps in and looks at our metrics and kind of checks in on all of those patients. And that was one of those utilized options over the last 2 years, just to kind of stay on top of those because, canceled visits because of sick, patients or patients that were fearful of coming into the clinic just for a routine blood pressure check. So utilizing those options, I think is really paramount. So
I will also add to that. I would definitely say that we have taken advantage as a clinic of those telehealth opportunities, and patients have really grabbed onto that as well. It's a really nice, accessible touch point for them, as well as for our providers, for patients who aren't able to get in, whether that be, like you said previously, transportation barriers or COVID, or they had a contact that maybe had a positive and they aren't sure and want to be extra safe. And then I will also say that patients seem to be really motivated by the COVID-19 pandemic, whether that's in a good proactive way or maybe in a negative self-impacting way. So some patients really responded well to the pandemic and said, I want to take in control of my health. And they went ahead and got these self-monitors at home and have been calling in to the clinic chart providers for those blood pressures, as well as more telehealth appointments for those if they aren't able to get in. So that's been really nice for them to take that initiative for their own health and us to be able to have that discussion over that telehealth appointment.
There is a question related to access and access to devices. Are there any tips on increasing access for those devices, especially for underprivileged clients who cannot afford and are not on health insurance?
At least one option that I'm aware of, if patients are not obviously in the active COVID infection and they have completed their isolation requirements, or if they don't have COVID, lots of pharmacies do have blood pressure monitoring systems that you can go straight into their pharmacy and check their blood pressure. It gives instructions on how to check the blood pressure and we'll do it right there for them. So they don't have to necessarily have a device in the home if they're able to get to their local pharmacy. That is also an option too.
Yeah, and I'll offer, depending on what part of the country that you're tuning in from. But for example, in St. Louis, there are some programs, community programs, where if referred into the program, a blood pressure device is included. A good example of that is the YMCA's blood pressure self-monitoring program. And it is, in some cases, a referral from a provider, or in some regions of the country, it's a self-referral. There might be a small cost, but, I would, reach out to, whether it be a United Way or some sort of, kind of 211 system, to ask that same question. And I know we get a common question like that here at the American Heart Association, and we certainly are engaging a little bit differently depending on the community we're working in. But there are definitely community-wide programs that help to address the access to devices. In some parts of the country, for example, we've partnered with library systems where the library has become a loaner source for blood pressure equipment, and some additional community education. So reach out to the American Heart Association staff in your region, or a United Way or others, to be able to see if there's some things that are already addressing some of those gaps. But certainly it is something we hear a lot, access to devices.
Mhm.
All right, so I'll do one more call for questions. Make sure we don't miss anyone. Oh goodness, hold on. Hit the wrong click. Someone shares Utah Health Department have them for offices that are willing to do SMBP. So yeah, so keeping your eyes and ears open to some of those opportunities. Yeah, it might be specific grants, or sponsorships, or community resources that are tied to other programs. Thank you for sharing that.
I know
All
the
right.
question was more pointed towards the uninsured, which keep in mind, you can write grants like internally through your health system to have start your own kind of loan program. So that's something that we've been able to do, and maybe not system wide, but for several clinics, we've been able to get some blood pressure monitors that way too. And then the other thing is just to mention that through Medicare, sometimes those plans will, especially Advantage plans, will have a flex account that can be used towards blood pressure monitors. So those are a couple of things just as a reminder, even though that's maybe outside of the question that they asked. But
no, thank you. And I'm going to drop in the chat as well. If you are interested in establishing your own loaner program, or want resources on SMBP, our targetbp.org website has a good number of downloadable resources. The Target BP program is a collaboration with the American Heart Association and the American Medical Association. We do recognize clinics for their control rates of their patient population, but the resources are available to anyone. So I'll drop that link in the chat and share it after today's webinar as well. Well, with that, I want to thank everyone for joining us today, and certainly to our panelists and experts for lending your time and your expertise. I always gain so much information at every one of these, even when I help to bring them forward. I do want to remind everyone of our next and last workshop in this particular series. And it's going to be featuring our National Hypertension Control Initiative. It is June 1st, same time, same place. But we do ask that you register for it. And I, again, want to thank our partners in bringing this series together. And so as we close out today, I do have, we've talked a lot about patients and supporting them And we also, need to remind people to get back into the doctor's office. If it's been a while since those in our community that have seen their primary care physician or their healthcare team, we want to get them back to those regular routine visits and managing hypertension. So as we close out today, we have a campaign at the American Heart Association that's called Doctor, It's Been Too Long. So we'll end with that video. We again thank you for joining us today, and hope you will join us on June 1st for the third and final of our series.
It's not just saying I love you. It's not just a warm hug or a hand to hold. Loving my family means helping them get the care they need to control serious but manageable conditions like high blood pressure and diabetes. Because acting now can help us have more healthy years together. My world is better with Mama, Pops, Auntie, and Tio. It's time we check up on our health and the health of those we love. Because, Doctor, it's been too long.
All right. Well, thank you again, everyone, for joining us here today. We hope you have a wonderful rest of your week and a healthy weekend. Thank you, everyone.